Dissociative Identity Disorder. I'm starting the series or the chapter on dissociative disorders in my series, Demystifying the DSM. I'm Christy Bundakumara, Dr. B, psychiatric nurse practitioner with over 20 years of clinical experience. And today I'm talking about dissociative identity disorder, which people often call multiple personality disorder. I think this is a popular diagnosis as far as the movies go, and we often, watch films or sitcoms, and that kind of display this dissociative identity disorder. But it's actually very rare. I've been practicing over 20 years, and clinically, I have probably seen a legitimate 2 dissociative identity disorder. Why is that? I think mostly because there's a lot of comorbidity with dissociative identity disorder, and there's other reasons that someone could disassociate. And so with this disorder, although it is popular in the films, it is actually clinically very rare. So what is disassociation? This is when we are not, or the person is not able to integrate things about themselves. So they could be different emotions, different personality types. It could be just like physical, being able to integrate all of the things that you want to do, right? So in a healthy mind, we are able to integrate our experiences, our emotions, and in dissociative disorders, there are periods of time where they are not able to integrate. So today we're talking about dissociative identity disorder. DID is what we often call it, and people often talk about it as multiple personality disorder. So if you've been following me in this Demystifying the DSM, you know that each disorder actually has to meet very specific criteria. So DID has an A through E, and criteria A is there has to be 2 or more very distinct personalities, okay? And when I'm teaching students and I'm talking about how do you differentiate, oftentimes, people with personality disorders and other comorbidity will come in and speak about having 2 personalities, or speaking of their inner child. And we have people who are psychotic who will tell us they have 2 different names. They will present as 2 different people. Clinically, we have to be able to differentiate. And the way that I like to teach my students is I'll say, in true dissociative identity disorder, when you encounter the 2 or more personalities, for you as the receiver in the communication, you feel like you are talking to 2 distinctly different people, kind of like talking to identical twins who physically look the same. However, they have very distinct mannerisms, personality, and if you talk to 2 twins long enough, you will be able to tell the difference between the 2 twins, right? There's more to a person than a physical appearance. And so in true dissociative identity disorder, it's like you're speaking to twins, but it's very different. The mannerisms, how they use their hands, how they use body language, the affect that they have on their face, the memories that they have, the perception of the memories, right? 2 twins could actually experience the same event, but tell you or perceive it differently, right? Same with a dissociative identity disorder. So think about it as 2 very distinct personalities. Comparing it to the psychotic patient that comes in, and there's other symptoms of psychosis we see, right? And there's the other symptoms of psychosis are going on, but maybe they are telling you that they are 2 different people. Okay, so as a clinician, if these are clinicians watching, you You really have to be able to determine that or see the difference. If you have a family member who you believe has DID, look for other symptoms of bipolar, of psychosis, of personality disorder. See if we're not actually dealing with more of a psychotic disorder rather than true dissociative identity disorder. Research shows that, there's a lot of people with DID who experience trauma. I like to say that, yes, this is true. However, we don't want to go into any situation clinically and assume trauma. This has actually personally happened to me when I was struggling with an eating disorder in my 20s. The clinician told me, research says that people with eating disorders have been sexually assaulted or molested, and that had never happened to me, right? So be very careful with, absolutes in psychiatry, psychology. There is no such thing as absolutes. But we do believe that there is some sort of break, likely during trauma, that the person splits, where they become two or more people as a maladaptive coping. So, criteria A for dissociative identity disorder, DID, is that there are two or more very distinct personalities. Criteria B is that there is a gap in memory, that these two people are experiencing life very differently, including what they remember about events. Criteria C, which is in every DSM, is that there is clinically significant distress. Criteria E is that this is not cultural, right? This didn't happen during a cultural ceremony where someone, may be disassociated for a period, or there is a, spiritual component where the culture as a whole believes that they were possessed. Be very careful with these kinds of things of possession within religious organizations. But if the person believes and the whole culture believes that this was an isolated event, then it is more of a cultural experience or spiritual experience. But dissociative identity disorder happens in all facets of life, not just at church or at a ceremony. Criteria E, that this is not due to substances, right? Unfortunately and fortunately, where people are experimenting with psychedelics. We know that psychedelics can allow us to be a great treatment for refractory depression, but they are not good for psychosis. So if there's psychosis, these psychedelics can definitely cause some sort of separation of integration. Remember when we talked about in the beginning, what is disassociation? It is not being able to integrate reality in different facets. Okay, so those are the criteria to meet for dissociative identity disorder. And remember, I'm going to go back to A several times because it's very important that just because someone identifies as more than one person does not equal dissociative identity disorder. There has to be a gap in reality. There has to be a separation of integration. Like I said, you're talking to two or more distinctly different people. Okay, and not the joke of, I don't know how my wife's going to wake up this morning, whether she's going to be in a good mood or a bad mood. It's still your wife. It's still the same person. She still has those memories. There is still an integration. Change in mood is not dissociative identity disorder, and in extremes could be more of a bipolar disorder. So looking at those differentials, when we say differential in psychiatry, we're saying, what other diagnoses could be going on to explain why the person is presenting as more than one person, right? And I do see a lot of kind of personality disorder comorbid with trauma and bipolar that do have some dissociative events, which we'll talk about other dissociation later, that present as DID. It's almost like because of the popularity, it's a diagnosis that people think is interesting. So also kind of weeding out, is this a personality disorder? Are they just presenting as two people, or they're really distinct personalities? And this is where in psychiatry, clinically, we have to get really, really good at what we call the mental status exam. This is where I can tell the difference with someone who is presenting as two people versus someone who really is two distinct persons. And you see that in, the affect and the perceptions and the mannerisms and the way that they're presenting, the way that they're speaking, their thought content, their thought process, those things that are in the mental status exam. That's how you differentiate. If both personalities are presenting the same in a mental status exam, then they are presenting as two people, but they are not actually disassociated of two people. So remember that disassociation can be from other disorders. We often see some disassociation in post-traumatic stress. So again, looking at the big picture. And then I want to go back to, what is the goal? What is the treatment goal for dissociative identity disorder? It is integration. We live in a culture where we want and should accept people where they are. And sometimes in that, patients, present, these two personalities, and they are almost feeding into both of those personalities. Well, this person is this way and this person is this way. It doesn't matter whether it is true dissociative identity disorder or comorbid with something else and presenting as two personalities. The goal of treatment is always integration. We should know who we are and know all of the parts of us, right? Insight equals confidence. I talk about this a lot with the Mentally Strong method in cognitive behavioral therapy. Now, we might need, professionals will likely need to do more specific techniques on dissociative identity disorder for that integration. But once the integration begins and there is some awareness of what is going on, that there are these two personalities that the individual is trying to integrate, right? This needs to be brought to the consciousness, because it is an unconscious, in true dissociative identity disorder, it is unconscious. The patient has no idea, or one of the patients have no idea that they are maladaptively coping and not integrating, right? But once they get to that point where they know, it is brought to their awareness, it is conscious, and they are attempting integration tools, this is when cognitive behavioral therapy is very important, right? What choices are we making in order to integrate, to stay integrated, to stay with insight? Working through those emotions that cause the disassociation. So we know that disassociation is what we call a maladaptive coping. It's unconscious. We are, the person is not doing it on purpose, but it is still a coping mechanism that is causing significant distress. It's not working for them anymore. We sometimes talk about children who are experiencing excessive trauma. And during that trauma, they disassociate to protect themselves. That is, a coping mechanism that worked for them at the time that it was happening. However, once you're safe and you are still disassociating, then we have to learn new coping skills. We actually have to address the emotions behind what we call the switch, right? We have to address the emotions and, the trauma, if there is trauma, so that you can bring all that to consciousness for integration, right? So DID is a very complicated and definitely needs professional intervention. At Mentally Strong, we can help with the medication management and the cognitive behavioral therapy and work directly with your professional therapist that has very specific training and experience in DID, if that is truly what you're dealing with. If this is more of a comorbid condition, bipolar, schizophrenia, we are able to handle that from a medication management and cognitive behavioral approach. So I hope you are not dealing with this in your life or your loved one's life, but bringing it to consciousness, not ignoring it, is the first step. Then seeking treatment and a therapist, specifically trained in DID, as well as some cognitive behavioral approaches, likely with some medication management, although there's not specific treatment for DID. We know that as far as medication management, we know that this is likely due to trauma. We know that it is a maladaptive unconscious coping to stress. And so, likely we can find medication to help with those things. So, demystifying the DSM, we're going through that. We're in the dissociative chapter, dissociative identity disorder, a complicated 2 or more very distinct personalities. Keep following as we go through demystifying the DSM. If you got to the end of the video, you obviously enjoyed some of the content. I have a lot of free content out there. I am really trying to empower everyone to find their mental strength. So subscribe, get the actual notifications, and let's embrace this journey of mental strength. See you there.